Hi, good morning everybody. Now I am going to demonstrate a case of lap partial nephrectomy. We did our last lap partial nephrectomy on 15th October 20. It was a right sided small renal tumor, as you can see in the CT scan. Though it was a small tumor, but the case was little difficult because the patient is heavily obese, having BMI 37. The first step of either laparoscopic radical nephrectomy or partial nephrectomy is the mobilization of the colon. Here there is little adhesion with the parietal wall. We are removing this adhesion with ligature. Mobilization of the colon can be done either by monopolar hook or by monopolar scissor or even advanced energy source like ligature, harmonic scalpel or thunderbit. Most of the cases usually there is a very good cleavage plane persists between mesenteric fat and serratus fossa, but in this case due to lot of fat obtaining the cleavage become a bit difficult. So, we are trying to obtain that cleavage plane between the serratus fossa and mesenteric fat. You see thick layer of fat over the serratus fossa, which I am incising with monopolar hook. I will mobilize the ascending colon and hepatic flexor. You see the thick pad of fat over the serratus fossa, and this thick fat belongs to colon or mesentery. You can appreciate that we got the cleavage plane between the serratus fossa and the colon. We are trying to mobilize it medially. Now you can see the duodenum. Immediately after mobilizing the duodenum, you will get the most important first landmark for right sided nephrectomy is the IVC. In most of the cases where the patient is not that much obese, IVC can be seen even without mobilizing the duodenum. The belly is too bulky, we even cannot retract the liver properly. To retract the liver, we usually put a port in the epigastric region, but in this case we put the liver retracting port much medially. Even then the adult forceps cannot reach up to the parietal wall. So, we could not retract the liver properly. I am incising the peritoneal reflection along the under surface of the liver. You can see the IVC there. Below is the duodenum, and mobilizing the duodenum we will be able to get the IVC. That is possibly the gonadal vein, and which opens into the vena cava. Whenever you will get the vena cava, it is easy to get the renal vein. If you follow the lateral border of the IVC, definitely you will get the renal vein. But usually we do not directly dissect into the hilum. We try to elevate the gonadoureteral complex at the following the psoas major muscle along the lateral border of the IVC. We reach to the hilum and we try to dissect the hilar vessel. I open the gyrotous fascia at the level of the lower border of the lower pole of the kidney, where the gyrotous fascia is usually thin. In this case, as it is not a case of nephrectomy, I will left the gonadal vein medially. I will go lateral to gonadal vessel. Instead of elevating the gonadoureteral complex, I will just elevate the ureter along with surrounding fat. Here I am incising the gyrotous fascia and trying to expose the psoas muscle, which is another important landmark for doing laparoscopic nephrectomy. Now you can see the psoas major muscle. In case of radical nephrectomy, we elevate the gonadal vein along with the ureter and follow the lateral border of the IVC and easily reach up to the hilum of the kidney. In this case, I did not omitted any steps of operation. I just increases the speed of the video 1.5 times. I am trying to go to hilum, but as I left the gonadal vein medially, some fat is remaining attached with the psoas muscle. Simple monopolar hook is good enough to dissect the hilum. You can see the renal vein now. Whenever you will get the renal vein, you will get the renal artery immediately behind the renal vein. Here you can see a artery, but this artery is a small one. So I am thinking that it might be branch. So I am dissecting above the renal vein, and you see I got the main trunk of the renal artery. Above the artery there are adventitial coverings. This is to incise with hook. At my right hand working port, I put a disposable Ethicon 10 port because it helps to put the suture materials easily inside, but my 10 forceps is not easy through this port. It is very tight. That is why I cannot work properly with 10 instrument. It's very tight. It's gripping. So, after completion of dissection of the pedicle ready for clamping, I am trying to mobilize the kidney. But you can see there is heavy perinephric fat which makes the mobilization difficult. Usually the mobilization of kidney is not a difficult task, but here you can see very thick fat, and I am trying to incise this fat with ligature. This is the anterior branch of the main trunk. In this case, mobilization of the kidney took longer time than usual, because at the region of the tumor level there is very toxic fat, and that toxic fat is firmly adherent with the with the tumor as well as upper pole of the kidney. This is very difficult to separate from the kidney. As the tumor is located at the convex border of the kidney, without complete mobilization of the kidney, it is difficult to resect the tumor. You see, the fat is very toxic and very firmly adherent with the kidney. And the posterior surface of the kidney also, the fat is very firmly adherent with the renal capsule. am struggling for complete mobilization of the kidney. Now the mobilization is almost complete. You can see the tumor. This is partly exophytic. You observe that to reduce the ischemia time, I am putting the suture material inside before starting the resection, so that after resection we can immediately start rhinography. I am marking the border of the tumor with monopolar scissor. Now I will apply bulldog to the both renal artery and vein. I applied bulldog to the renal artery, and now I will apply bulldog to the renal vein. And I am going to start resection of the tumor. Not only during the resection, during the whole procedure, the role of assistant is very important. During resection, he has to retract the margin of the tumor and to suck continuously, but unfortunately my regular assistant was not present in this case. However, we resected it nicely without breaking the tumor capsule. took a little longer time than as usual. It's good encapsulated tumor, so it becomes source of nuclear resection. Tumor capsule remains intact. My right hand scissor is not working properly. Now it is time to do the rhinoplasty. I am suturing the kidney with 20 Vicryl. Tumor is not that much deep, that's why there is no major vessel or no opening up of the pelvic calyceal system. So I am overrunning the area with 20 Vicryl, and that is the first layer of rhinoplasty. Our total ischemia time was less than 30 minutes, almost 30 minutes. first layer of rhinography is completed. Now I will do the second layer to oppose the margin of the kidney. I am putting a pad of fat into the tumor bed. Rhinography is almost complete. After completing the rhinography, we will remove the bulldog clump. Now we will remove the bulldog. You can see there is no active bleeding. Now we put a gloves back for retrieval of the specimen. One thing is important, if it is possible to cover the kidney with the Gerota fascia, it is always better to cover it with Gerota's fascia. I am covering the kidney with the Gerota fascia, putting a stitch. We removed all gauze pieces, needles and bulldogs. the specimen, slightly enlarging our camera port, putting a drain in the renal bed. Thanks for watching.